Okay. Yeah. ಇಲ್ಲ ನಿಮ್ಗೆ ಆಮೇಲೆ ತಲೆ ತಿಂದ್ಬಿಡ್ತಾರೆ ರೆಕಾರ್ಡಿಂಗ್ ಬೇಕಂತ.
Yes, sir.
Okay. Okay.
Are you able to see my slide, sir?
Yeah. Very
Yeah.
much. Very much.
We'll start off.
Yeah.
So, good evening, everyone. So, we just thought we will discuss some things specifically related to non-invasive monitoring in neurocritical care. What better way than to start off with basics of neuromonitoring and what are the guidelines or the
Sir,
what are the,
voice is not clear.
one second.
Sir, voice is not clear.
Yeah, one second. Is it audible now?
Yeah.
Yeah, Vinay.
Yeah. So what better the way to start off this than to sort of run through the latest guidelines, be it B Iconic 1, which was released recently this February, March, which stresses the importance of non-invasive ICP monitoring in specifically in brain injured patients secondary to traumatic brain injury. So we'll just run through the neuromonitoring slides. Before we start off, none of us are experts in the field. It's just our enthusiasm and our interest in this field. If anyone has any inputs, please feel free to add on. I think a lot of the experts, a lot of them who are already practicing or already there. They started off mainly as to enrich, or let's say to teach our trainees, and now it has sort of become more formalized, and we are doing the first meeting. We can plan for two or three, have 180, 190 slides with the 30 to 32 case scenarios. Today we'll be covering neuromonitoring and basics of transcranial Doppler. So quickly jumping into the neuromonitoring. So identification of primary brain injury and prevention of secondary brain injury, which is most commonly neglected, is important to have good clinical outcomes in the ICU. Secondary brain injury is often an overlooked entity in the ICU, and there has been various models which are described. And the most classical ones was described by Rosner, which has been called as Rosner's conjecture, which comprises of systemic as well as local factors contributing to the secondary brain injury. Critically ill patients are predisposed to secondary brain injury, not just from the primary brain illness alone, but also due to other systemic illnesses. Hence, neuromonitoring is essential not just in brain injured patients, but also in the systemic injury. As we all know, the brain has a poor physiological reserve in contrast to the good physical reserve. The one size fits all approach, like let's say a GCS of 12 without any systemic injury behaves differently, or in comparison to a patient with a GCS of 12 and who has severe lung contusions or who is severely hypoxic. Hence, one size fits all approach, or what we call as protocolized approach, is often erroneous, and there is a need to have a phenotype of all the injuries. Hence, neuromonitoring is done to address and identify such pathophysiological heterogeneity, and also to identify various phenotypic diversities. Our neuromonitoring techniques target to identify what is defined as brain shock, and to further phenotype and personalize the treatment. So there are various mechanisms of secondary brain injury. That's what we are concentrating, or let's say to prevent the secondary brain injuries, starting off from loss of autoregulation, diffusion limitation, reduced oxygen distribution, to mitochondrial dysfunction, calcium-related excitotoxicity, cortical spreading, depolarization, and depressions, and also the reduced capillary transit times and the shunts. All these can contribute and add on to the primary brain insult. So what are the domains which we have at our disposal, or what are the domains of neuromonitoring which are available, which is beautifully described by Professor Arti Sarwal as analogous to the model of the house, which comprises of a plumbing domain, the electrical domain, the ventilator domain, and the structural domain. Before we get into these modalities, always for all of us, clinical examination remains the foremost importance. So hence, ESICM recommends neurological examination in the ICU at least once, and with possible interruption of sedation. If interruption of sedation is considered safe enough. And all the clinical states such as coma, delirium, all the other strength, motor strength needs to be examined using various validated scales. The whole aim of such a clinical examination is to identify what is called as a critical neurological deterioration, or what we call as critical neuroworsening. What are the components, or what comprises of critical neuroworsening? The drop in the motor scale of at least one or more, decrease in the pupillary reactivity, any pupillary asymmetry or bilateral mydriasis, a new focal neurological deficit, or a herniation syndrome or a Cushing's triad component. This is the whole idea of us doing a clinical examination to identify the critical neurological worsening or critical neuroworsening. And once we identify critical neuroworsening, we need to choose one of the modalities or one of the domains of neuromonitoring to select an appropriate intervention, either in the form of a surgical or anticipated or the elevation in the tier of management. So coming to the structural domain, I have just clumped it up together so that sort of a pictorial memory is retained. And what are the components of structural domain? Neuroimaging, as we all know, I will not go much into the details of neuroimaging, CT and MRI, and various sequences of MRI. ONST, this is of interest for us for this discussion. We all know that it's done using a linear probe. Recently, a review article has been published, which gives us categorically how do we measure optic nerve sheath diameter, the most specific component of the three things which is represented in optic nerve diameter, optic nerve sheath internal, and the optic nerve sheath external. The optic nerve sheath internal diameter is what we need to measure, and the cutoff selected according to that paper was more than 5.8 was considered pathologic, and the recent guidelines have pushed it up to the level of 6 mm. And the third component of the structural domain is the automated pupillometric device. So this adds objectivity. So we do measure pupillary reactivity in sunlight, in dark, or with the help of when there is light or when the light is dim. So we need to sort of objectify, and it's very difficult to put it across in numbers. Hence, the APD device adds such an objectivity based on the size, latency of contraction, and the contraction velocity and the dilatation velocity. They have devised something called as a neurologic pupillary index, where more than 3 is considered normal. Anything less than 3 or a baseline value of x minus 1, if there is a drop in 1, is considered abnormal, or it raises the suspicion of raised intracranial pressure. Coming to the plumbing domain. So the plumbing domain comprises of pressure, oxygenation, and the autoregulation component. With respect to the pressure, you know that TCD forms the major component of a pressure domain, along with the ICP. Either ICP probes can be either ventricular, interparenchymal, and various others. Coming to the oxygenation, either it can be non-invasive or invasive. Non-invasive through SNIRS, whereas invasive is through the tissue oxygenation, which has been incorporated in the CBIC algorithm, and they have phenotype patients as per the ICP and the PbTO2 as A, B, C, and D. And the other oxygenation index is the SgVO2. And the third and the final component of the plumbing domain is the autoregulation domain. Even the autoregulation domain has a importance, or let's say TCD can help us determine the autoregulatory status. So this comprises the plumbing domain. Coming to the metabolic domain, the micro, or let's say what are the substrates produced by the brain, and what is the oxygenatory status, or how is the metabolism ongoing, which is detected with the help of a cerebral microdialysis catheter and pyruvate lactate ratio, along with other components indicating the oxygenation status of the brain, which is again, personalizing the brain injury and phenotyping the brain injury. The only disadvantage of it being it is invasive and frequent sampling is required. The biomarkers are again the metabolic indicators of the brain. There are various biomarkers available. So the most important biomarker being the NSC, which we do consider in cases of post-cardiac arrest injury, and other novel upcoming algorithms integrating biomarkers into the brain injury, especially mild and moderate traumatic brain injury, to have a algorithm or to have a care pathway to decide whether the patient comes into the ICU or directly goes to the high dependency unit, because depending on the biomarker being positive or not, or the newer applications of biomarker related outcomes. So the final component of it is being the electrical domain. We all do this continuous or the intermittent EEG monitoring, bispectral index, the quantitative EEGs, the NCS and ENMG. If at all we are having a confusion, or let's say there is a doubt in the peripheral nervous system related abnormalities. So these comprises four domains: the structural, the metabolic, the plumbing, and the electrical domain. So now we have these four domains. Do we need to choose all together at once, or we need to choose? How do we choose the modes, or let's say how do we determine which mode to be taken when, or which is the most commonly used mode? So we need to decide whether it's unimodal or multimodal. So the clinical algorithms, that is the ICE protocol, which is the acronym for imaging and clinical examination based protocol, which was incorporated in the best trip trial. That was a landmark trial, did not lead to any superior outcomes, where they compared invasive ICP in comparison with the imaging and the clinical examination based protocols. So that did not lead to any superior outcomes. So in the same way, the CPP versus the ICP guided approach also failed to show any neurological superiority in the outcomes. Hence, a bundled phenotypic approach combining various domains of neuromonitoring are important to are necessary to improve the clinical outcomes. Hence the term multimodal neuromonitoring, which is defined as the time synchronized integration of neurological examination with other physiological parameters via invasive and non-invasive modalities. So multimodal monitoring has come in a big way and has also got incorporated into the CBIC algorithms and also the latest trials like Cogitate, Boost, and hence we need to go ahead with not just ICP or a CPP guided approach. It has to be always multimodal, and this is where our TCD plays an important part. So in an analysis, this again indicating there was a meta-analysis done of using 112 multimodal monitoring studies, where the most commonly combined approaches were 52% use two modalities, 25% use three modalities, and only less than 25% of the patients use more than three modalities. So the best way to go ahead and monitor the patients addressing various domains would be a combination of either two or three modalities. This again indicated in this Sarkos plot, which shows that the invasive ICP monitoring being the main or the most commonly used parameter, followed closely by the tissue oxygenation, and which is closely followed by close third for the transcranial Doppler. So this is where the importance of transcranial Doppler is. Okay. So this is again the same thing in the two algorithm or the two mode combinations. The ICP and PbTO2 was the most commonly combined modality, followed by in the three modal combinations, it was ICP, PbTO2, and the TCD. So TCD does form an important and an essential part in monitoring the patients, and also as a part of multimodal neuromonitoring. So why do we need multimodal neuromonitoring? This picture represents, so if anyone can unmute themselves and look into this and identify anything is abnormal or abnormal, because both the absolute numbers are the same. The absolute numbers of ICP is 7 in the preset A, and absolute number of ICP is 7 in the preset B. So anyone can unmute themselves and comment about this.
V2
Waveforms
is
are different.
Yeah. So apart from that,
there is bradycardia and hypertension.
yeah. So possibly this patient, if was picked up early in the stage A, not by using not just the ICP number alone, if we had combined other modalities, other domains, if at all they were used, we could have possibly averted this scenario. Or few hours later, this patient went on to go into decompression state, and patient are already decompensated by then. So if we take just an absolute number, this is the importance of a unimodal, no drawback of a unimodal approach. The absolute number has remained the same. but the physiological status or the physiological reserve of the brain has decompensated very much. So this is again the same phenotyping, and hence TCD is very important in phenotyping this patient. The possibly the image in the preset A, the patient was sitting at somewhere in the phenotype C, between A and C. In the image in the preset B, possibly the patient was already in somewhere in the upward slope of phenotype C, and a few hours later, patient decompensated. So, like many things in critical care, even the pressure and the oxygenation curve of the cerebral compliance follows this sigmoid shaped curve. Hence, application of multimodal monitoring techniques, not just the unimodal approach. Either it can be combination of TCD, ONSD, or clinical examination. That is the imaging or the ICE protocol, what we call as, is very much essential. It's not like we put an ICP and we tend to forget looking at just the number. We need to monitor TCD, and this is where the role of TCD and the non-invasive monitoring devices are. So again, coming to the disease-specific modalities which they have mentioned in that meta-analysis. So in most of the places, TCD finds its place, and hence integrating TCD in our routine clinical practice is very much essential, except for possibly the electrical domain monitoring of the neurological system. Most of the other clinical states have TCD as a possible mode of monitoring such deterioration. Even the metabolic domain also, possibly due to the local changes in the internal milieu, possibly there are changes in the TCD which we can expect. So just to quickly debrief, multimodal monitoring is superior to unimodal, and multimodal monitoring allows for a personalized approach rather than a protocolized approach as we progress towards the precision medicine. And neuromonitoring forms an essential part even in the non-brain injured patients due to already well-established organ crosstalk and development of institution and region-specific algorithms integrating the non-invasive modalities are essential. The CIBIC ICE crevice protocols based on based on the availability of the invasive and the non-invasive modalities have been devised. I request every one of us, we need to be aware of these CIBIC, ICE, and crevice protocols. They have devised it based on the availability of the invasive and the non-invasive ICP monitoring. So the latest child on the block is the B-ICONIC, the Brussels consensus, which was recently published for the non-invasive monitoring in patients with traumatic brain injuries. So we all need to know that the domains are not exclusive. The domains and modalities are not exclusive, as we saw in that image. They are just complementary, and they have to be used, respected mutually, and they're used in a complementary and a context specific manner. This is the B-ICONIC guidelines. As we jump into the non-invasive part or the core part of this discussion, the Brussels Consensus Conference, which gave 34 recommendations. I've highlighted a few recommendations. So the first recommendation, which they still highlight, is in any patient who is having a severe traumatic brain injury, always invasive ICP monitoring has to be considered. So where does the role of non-invasive monitoring arise, or where do we sort of stand on this non-invasive ICP monitoring, where there is a resource constraint, or we are waiting for the ICP monitoring. We cannot wait for the escalation of the tired therapies. So that is where possibly the most important role of non-invasive monitoring arises. So the second recommendation which I would like to highlight is the main tools, or the tools which they have recommended in this guidelines, are the neurologic pupillary index, or the automated pupillometric device, the pulsatility index derived for the TCD, and the non-invasive ICP formula of device, approximated from the TCD, either using a Bellner's or the CPP formula, and the fourth one being the optic nerve sheath diameter. So these four have been recommended by this consensus, this guidelines, to sort of incorporate into the clinical practice. And we recommend that the guidelines recommend that there is always multimodal approach is what needs to be employed. And amongst these four suggested modalities, at least two different modalities needs to be implemented, and two different modalities needs to be better or worse to decide on either escalation or de-escalation of the thyroid therapy. And again, the fourth important recommendation which I highlighted is there needs to be integration of imaging and clinical assessment. So imaging and clinical assessment cannot be forgotten even if we perform a non-invasive ICP measurement. The other one being that we recommend that it has to be done, or the non-invasive ICP estimation has to be done in a serial manner. It's not just performed at once and forgotten. It's always good practice to have an established baseline and continued monitoring as the time progresses, or the time as the patient continues to remain in the ICU. So they have given a recommendation in patients with severe TBI, non-invasive ICP monitoring needs to be done every second to fourth hourly, and patients with moderate TBI, the time frame is a little bit lax, being probably 4 to 6 hourly we can monitor. And the most important being, no, they recommend the use of non-invasive ICP monitoring in moderate TBI in the presence of extracranial injuries, especially in cases when there is presence of traumatic brain injury with a coexistent lung injury, which of late we have found to be very useful in our settings, where patients who have come in with moderate TBI and very bad lung contusions, where we have been compelled to sort of give lung protection by employing deep sedative and neuromuscular blockade, where we are tied in assessing the neurological status. And hence non-invasive ICP monitoring are sort of tailor-made circumstance for it's a tailor-made circumstance for employing this monitoring devices. So what are the seven abnormal things which they have indicated in this Brussels criteria, that is non-invasive ICP estimated by the equation to be more than 20 to 22 mmHg on any side, and ONSD being more than 6. Pulsatility index, it is one of the it's one of the indices derived from the waveform, from the spectral tracing. If at all it's being more than 1.3, so up till this guidelines the cutoff was 1.2, they have pushed it a little bit higher to 1.3. And the most important one being the in combination with the reduced diastolic flow velocities. So pulsatility index alone being high is not equivalent to raised ICP. It has to be always accompanied with the low diastolic flow velocities, because pulsatility index can have a lot of confounding factors in the form of carbon dioxide, anemia, or let's say other factors. Hence, it has to be always in conjunction with the low diastolic flow velocities. The fourth one